so we can stay on time. Thanks all of you for attending today. I think you'll find that it's been time that will be rewarding for you. So you're going to hear the unveiling of the INHALE-3 randomized trial results today. And this is what we have lined up for you. We have a star-studded cast of speakers who are going to talk first about background, then about results of the study, and then about interpretation. And so I think with that, we will get started. And our first speaker is Hallis Khan-Atkert from the Barbara Davis Center at the University of Colorado, and he's going to talk on some background about insulin, inhaled insulin's history and the rationale for the study.
So in 1997, Elman saw the potential of a dry powder insulin formulation to achieve more rapid absorption into the bloodstream than possible with the subcutaneous injections. Over $3 billion has been invested into Technosphere insulin, and more than 20 years took to bring to the market. And Technosphere insulin was approved by FDA in 2014. So if you look at the Technosphere insulin delivery system, and we have a Technosphere, and these are the microparticles of the FDKP, and then this is a drug delivery system, and then it's attached to human regular insulin. So we use the human regular insulin in the Technosphere insulin. And it makes the form of the stable form of the Technosphere insulin, which I will call as TI. And this is less than the pH 6 in the stable form. When it's inhaled by the lungs, when the pH is more than 6 in the physiologic pH in the lungs, inhaled particles dissolve rapidly and separate. FDKP and insulin then quickly absorbed across the lung membrane. If we compare the pharmacodynamics of the TI versus the rapid-acting insulin analog, and here is the orange line you see is the TI with the 12 units, and the red line is the Lispro 8 units. And you can see that in the other slides also I will explain the TI dose and the rapid-acting analog doses are not the same. It's not one-to-one. So to compare a fair pharmacodynamics, and this is the TI is 12 and the Lispro is the 8 units. So Technosphere insulin is in and out. So you can see that the TI maximum serum insulin concentration in 12 to 15 minutes compared to 45 to 60 minutes for the rapid-acting insulin analog. TI effect dissipates faster than the RAA, potentially reducing the post-meal hypoglycemia. You see here is the Technosphere insulin. We have a compact inhaler, and then we have 3 different cartridges. You see this, the blue one is the 4 units, green one is the 8 units, and the orange one is the 12 units cartridges. And when I say that for 8 and 12 units, these are the TI units. So these are not the same units with the rapid-acting insulin analogs. So according to the label, it's the 1 to 4 is the 4, 5 to 8 is 8, and 9 to 12 is the 12 units equivalent of the TI units. And these are the pre-filled single-use insulin cartridges. So you put this cartridge in this compact inhaler, then you inhale, and then you just change that for another inhaler if you need. You can see here in this video how it's inhaled. So if you look into the Technosphere insulin clinical studies, and Technosphere insulin has been used more than 3,000 patients across the studies in the last 20 years. And we have the Affinity 1 and Affinity 2 clinical trials, the pivotal trials that led to FDA approval in 2014. And since then, there are many studies tested for different indications, and we'll be talking about the INHALE-3 study results today. And INHALE-1 is the pediatric study that has been going on. So if you look at the Affinity 1 clinical trial, that's the pivotal trial in type 1 diabetes, and there are 2 arms. One is the TI with the basal, and other one is the insulin aspart with the basal insulin. It's more than 170 patients randomized, and there's a 12-week of prandial insulin titration phase, followed by a 12 weeks of insulin stable dosing phase. And at the end of the 24 weeks, and the TI and basal insulin was non-inferior to aspart and basal insulin. In a similar design, if you look at the Affinity 2 pivotal trial in type 2 diabetes, and then the TI added to oral antidiabetics, and compare with the placebo with the oral antidiabetics, again, more than 170 patients, and it's followed the same design as the 12-week titration and 12-week stable dosing. And you can see that TI added to oral agents was superior to placebo and orals in reducing hemoglobin A1C. If we are coming to the START study that we did in 2018, this is a treat to target study in adults with type 1 diabetes. It was a 4-week study, and we had 2 groups, and one group was getting insulin aspart for the all meals and for corrections as needed. Another group was getting Technosphere insulin and for the meals and just before the meal, and also at 1 hour and 2 hours as needed. So at the 1 hour, if the patient's blood glucose was 150 to 200, they were getting 4 TI units. If it's more than 200, they were getting 8 TI units. If at 2 hours, if the blood glucose is still more than 200, they were supposed to get another 4 units. Then we compare this people with the overall, the TI group and the TI compliant group. TI compliant group means that according to the protocol, patients should be taking more than 90% of the insulin. And all patients were using real-time CGM. So if you look at here in the START study results, and then you see that it's 60 and 90 minutes, and the postprandial glucose is significantly lower in the TI group, and insulin aspart glucose is higher, and this is statistically significant, and this can be explained by the in and out, the fast-acting, ultra-fast-acting effect of the Technosphere insulin. If you look at the postprandial glucose excursions for the breakfast, lunch, and dinner in that study, and then breakfast and lunch, you can see that the TI compliant group had significantly lower postprandial glucose excursion, compared to the insulin aspart group, but there was no difference at the dinner. And this can be explained probably some patients maybe not dosing properly and giving intentionally probably less in the fear of hypoglycemia. Maybe they were still thinking the physiology of the insulin aspart. And there was no increase in hypoglycemia in the START study in the TI group. If you look at the START study time in hypoglycemia and comparison between the compliant, non-compliant, and the overall group, and you can see that all groups in the all times less than 70, 60, and 50, and less than 4%. And if you see that is the TI compliant group, according to the protocol, when it's taken, and it was about 2.2% is the time below range. And we use this dose 1 scale, which is the label scale in our START study, and we realized that the people needs actually a little bit more optimization. And then this is a study that compared the dosing in the dose 1, which is used in the START study, and 2 times more dosing in the dose optimization study. And, as I mentioned in the dose 1 is if you are taking insulin aspart, for example, up to 4 units, you are supposed to take 4 units of, TI. 5 to 8 is 8, 9 to 12 is 12, 13 to 16 is 16. And that was compared with the 2 times more dosing, and you can see if it's taken 1 to 3 is 4, and it goes like this. And if we compare them for the postprandial glucose excursions, and you can see this dose 1 is the standard dosing, dose 2 is the 2 times more dosing, and you can see these all time points, 45, 60, 90, and 120 minutes. And you see the significantly lower postprandial glucose excursion with the 2 times more dosing. That's the base of the INHALE-3 dosing, and based on this study. If you look at the safety results, and we have the pooled safety results in type 1D clinical studies, and the most common adverse events reactions in participating with type 1 diabetes was that the cough. And this was about 29.4%. And is followed by throat pain or irritation, some other the rare side effects. If you look at the cough in more detail, and cough reported in 26.9% in the comparator, it was about 5.2%. 94% of cough episodes characterized as intermittent or single episodes. They were generally mild, dry, and brief, occurring shortly after inhalation. Frequency decline with continued use. And less than 3% of the TI users discontinued therapy in the clinical trials because of cough. And most of the time what we suggested is that, you can just take a sip of water before and after, and then most of the time it was no problem. If you look at the effect of TI on the forced expiratory volume, FV1, and then how it's affecting the lungs, and then you can see that comparing the comparator and the TI, more than 1,500 patients, the difference was about 40 milliliter average. And this means about 1% decline in the total lung capacity. To say that there is a significant decline, it should be more than 15% decline, and which was in reality, it was about 1%. In the pivotal trials, difference in the FV1 between TI and the comparators no longer present within the 4 weeks after discontinuation of treatment. If I summarize and my part, Technosphere insulin has more rapid onset of action and effect, dissipates faster than rapid-acting insulin analogs, and numerous studies have demonstrated that when combined with basal insulin, TI effect on hemoglobin A1C and time in range is similar or better than that of the rapid-acting analog plus basal insulin. Bioequivalent dose of TI 2 times more than the rapid-acting insulin analog dose, and 2 times more dosing when we convert. And if we also add some corrections at the 1 hour, is safe. Slight brief cough, usually tolerable, relatively common with inhalations. Slight FV1 reduction observed with resolves after TI discontinuation. Since FDA approval in 2014, in the last 10 years, no new safety signals identified. Thank you.
Thanks, Khan. I should have said in the beginning, we're going to have about 20 minutes for question and answers at the end, so please think about your questions and we will have time to address it. So our next speaker is Yogesh Kudva from the Mayo Clinic in Rochester, and he's going to talk about the study methods and the participant baseline characteristics. Yogesh.
Thank you, Dr. Beck. So these are my disclosures, and look at the clock for 6 seconds. Advisory panel and product research support, thank you. So with that background, we can look at the INHALE-3 protocol overview. So this was a randomized study, and subjects were randomized either to use degludec insulin along with the Technosphere insulin, or to usual care. The randomization was 1:1. This was a 17-week study, which had a primary outcome of hemoglobin A1C and was a non-inferiority comparison. The first 4 weeks of the 17-week RCT was used for dose titration, which we'll look at soon. And after the 17 weeks, there was the 13-week extension. And we are delighted that that was completed about a week ago. In that extension, both groups used degludec plus the Technosphere insulin. And the funding for the study was from Mankind Corporation. These are the 19 sites in the US that took part in the study, with the Jade Center for Health Research being the coordinating center. And the PIs are on the slide. Leave it for a few seconds and move on to the sample size and the eligibility criteria. So our recruitment target was 120, and a priori these were some of our recruitment goals, that about 40% should be multiple daily insulin users, 40% should be using automated insulin delivery, and a maximum of 20% with a central lab hemoglobin A1C of less than 7%. Key inclusion criteria were age greater than 18 years. They had to have established type 1 diabetes, so therefore at least 6 months of diabetes. As you can see, the hemoglobin A1C and eligibility criterion was broad, so up to 11%. And they had to have the same insulin delivery method for the last 3 months, be it AID or sensor augmented pump or MDI. The total daily insulin had to be in this range, 20 to 100 units. They had to be regular CGM users. As you can see, non-insulin glucose lowering medications in the last 3 months were not permitted. There were some respiratory exclusion criteria, as would be obvious. They should not be pregnant and DKA or severe hypo should not have occurred in the last 3 months before enrollment. And advanced renal failure was an exclusion criterion. They had to have baseline procedures, which are outlined here. So they continued to use their personal CGM and had a blinded Dexcom G6 Pro for 14 days. They had a blood draw for central lab, hemoglobin A1C, and baseline FEV1 measured. And they completed several patient-reported outcome questionnaires, as listed here. And they were randomized then to either degludec TI group, the intervention group, with the study Dexcom G7 CGM, or the usual group where they continued pre-study insulin delivery and used their personal CGM. They had a meal challenge at baseline, and subsequently they used either rapid-acting insulin or TI. The next few slides, we'll look at the dosing titration. So degludec dosing was started with the dose equaling their total daily basal units through pump or by injection. The dose was titrated every 3 to 5 days during the first 10 days, and then weekly, with the target of having the fasting glucose of 90 to 120 without hypoglycemia. On this slide, you can see the TI dosing. As we know, TI is available as 4 8-unit cartridges or 12-unit cartridges. The prescriptions have to be appropriately written for as far as clinical practice is concerned. The dosing was updated from previous studies, and on this slide you can see the updated dosing schedule. The initial dose was based on their typical rapid-acting insulin dose for the amount of carbs or size of the meal. So the conversion table is shown here for the sake of convenience. So if individuals were using 3 units, 3 into 2 is 6, and then rounded down to the nearest 4-unit cartridge would be 4. 5 into 2, 10, rounded down to 8, and so on. During the first 4 weeks, the meal dose was titrated based on 1 hour postprandial CGM. If the glucose was consistently greater than 140, the dose was increased by 4 Afrezza units. And if it was greater than 200, by 8 Afrezza units. If pre-meal glucose was in the range of 140 to 200, participants used another 4 units of TI, and if greater than 200, 8 units. And they were also given instructions to use a correction dose 60 to 90 minutes after the meal dose based on the glucose measurements shown here. Obviously, they had to be mindful of their CGM to implement this. The usual care group continued their pre-study insulin delivery method, followed their usual diabetes management, and had the same contact and visit schedule as the TI group, and changes were made in insulin dosing as indicated by the site clinician, by the site clinical investigator, I should say. So the visit schedule and procedures are shown here. For the first month, for insulin dose optimization in both groups, there were virtual visits as outlined, starting from day 4-8 afterwards every week. And then a blinded G6 Pro was used for 10 to 14 days after day 29. There were virtual visits at 8 and 13 weeks. And the primary outcome was assessed at 17 weeks with a visit. Prior to the visit, subjects used a blinded G6 Pro as the CGM used for analysis. There was a blood draw for central lab hemoglobin A1C, and they completed a FEV1 measurement and also patient-reported outcome questionnaires that we mentioned at the start. The study outcomes for efficacy, the primary outcome was hemoglobin A1C at 17 weeks, tested for non-inferiority. The CGM metrics time in range, time in tight range, mean glucose, time above range, and TBR, change in weight, and patient-reported outcomes. Safety assessment included severe hypoglycemia and the other endpoints listed here, including DKA and CGM time less than 54 and CGM-defined hypoglycemic events. Also analyzed were change in FEV1 and various other respiratory endpoints listed. The statistical methods, the primary analysis was intent to treat. Per protocol analysis accounted for exclusions as mentioned, and standard statistical methods for analysis of continuous variables as well as binary variables. On this slide, we can see baseline characteristics. So mean age of 45 years with women adequately represented, with about 23 years diabetes duration, and about 42 and 41% with education less than bachelor's degree and an income less than 100K. Individuals that did especially physical jobs, certain kind of physical jobs, were especially enthusiastic about this option, such as elevator technician and so on. So this is the body mass index of close to 28, and 89% were white, with the ethnicity listed below, 11% Hispanic. So 123 subjects included 48% AID users and 44% MDI users, being the two main groups. The AID systems used are shown here, and the total daily insulin was pretty standard. Baseline metrics included A1C 7.6% with broad representation, and TIR of 52% with low time below 54. So in summary, 19 US sites enrolled 123 subjects with AID and MDI being main cohorts. The random assignments are shown and the outcomes are mentioned here. So 141 screened to randomize 123 and assessed at 17 weeks. Thank you.
Thank you, Yogesh. Our next speaker is going to be Ruth Weinstock from SUNY Upstate Medical Center in Syracuse, and she's going to talk about the results of the in-clinic meal challenges that were done. Ruth.
Thank you. And these are my disclosures. The participants arrived for their meal challenges fasting, having not bolused insulin for at least 4 hours prior to the start. The glucose... Oh, sorry. The glucose values were greater than 90 and less than 220 milligrams per deciliter 15 minutes prior to the start of the meal challenge. And the meal was a boost that contained 37 grams of carbohydrate. AID or automated insulin delivery was continued if that's what the individual was using. And for the individuals who received inhaled insulin, control IQ was placed in sleep mode for safety reasons. Glucose was measured every 15 to 30 minutes through the first 2 hours, and blinded Dexcom G6 Pro data were used for analyses. For the initial inhaled insulin dose, we estimated that 2 units of inhaled insulin, or 2 inhaled units, were bioequivalent to 1 unit of subcutaneous rapid-acting insulin analog. And that is higher than the US label. So as discussed by prior speaker, we would take the rapid-acting insulin dose, multiply by 2, and round down to the nearest 4-unit cartridge. So for example, if someone was taking 6 to 7 units of rapid-acting insulin analog, they would receive 12 units of inhaled insulin. I'll first show the results of the baseline meal challenge. This was at randomization, where one group received inhaled insulin, their first dose, and the other group rapid-acting insulin analog subcutaneously. And we're comparing those 2 groups. The y-axis is the glucose change from the start of the meal challenge, with the red line being those who receive subcutaneous rapid-acting insulin analog, and the blue, the inhaled insulin. And you can see that the glucose change was less. There was less hyperglycemia over the first 2 hours for those who received inhaled insulin. And the inhaled insulin units compared to the rapid-acting insulin units, the ratio was 1.8. The area under the curve was less for those who received inhaled insulin versus rapid-acting insulin, shown on the upper left, and the peak glucose, time to peak glucose, and maximum glucose excursions were all lower for participants who received the inhaled insulin dose, or T1, versus the rapid-acting insulin analog subcutaneously. This slide shows our MDI users on the left, as well as those who were using a pump but not in an automated mode, and on the right, those using an AID or automated insulin delivery system. And you can see on the left, our MDI users had the greatest difference between the inhaled group and the rapid-acting insulin group, with less hyperglycemia after the inhaled dose, compared to, on the right, to those receiving automated insulin delivery, where over the first hour, the results were similar, and then they start to separate. And this slide shows the glucose excursions over 4 hours. By about 3 hours, these lines start to be similar. And I just want to note that in the actual trial, as was mentioned earlier, participants were instructed to give themselves an extra dose, another dose of inhaled insulin, if they were having hyperglycemia after a meal. That was not done in the the meal challenge. They only received a dose at the start of the meal for these meal challenges. For safety, we looked at hypoglycemia, defined as less than 70 milligrams per deciliter, and provided oral carbohydrate if that occurred. There was only one instance in each group, and one individual who received supplemental insulin for a glucose over 300. I'll now turn to the 17-week meal challenge data, and I'll start with the group that was randomized to receive inhaled insulin at baseline. And what we are going to be comparing here are the baseline meal challenge results to the optimized dose. As was mentioned earlier, participants titrated their inhaled insulin dose per their personal needs, so that by 17 weeks they were on an optimized dose, which turned out to be higher than the dose they were taking at baseline. And you can see here, again, glucose change from the start of the meal, where the green line is the randomization dose of inhaled insulin, and the week 17 data, when these same participants now were on an optimized dose, that the glucose excursion was less. There was less hyperglycemia after this meal challenge over the first 2 hours. The ratio of the inhaled insulin dose at 17 weeks compared to baseline was 1.5. And this shows the glucose excursion over 4 hours, again comparing in the green the initial meal challenge with the initial inhaled insulin dose versus the purple line, which was the optimized or larger dose. I'll now present the 17-week meal challenge data for the participants who were initially randomized to receive subcutaneous rapid-acting insulin analog. For these individuals, we're looking at the baseline meal challenge test with the rapid-acting analog versus receiving their first dose of inhaled insulin at 17 weeks. As shown on this slide, the green line, again, is their initial randomization meal challenge using subcutaneous rapid-acting insulin, and the purple line, the week 17 initial dose of inhaled insulin. Again, showing a difference with the lower glycemic excursion, less hyperglycemia after receiving the inhaled dose. The inhaled dose, the ratio of the inhaled units to rapid-acting insulin units was 1.8, which was the same as the ratio during the initial baseline challenges. And here we show the MDI, or multiple daily injection users, on the left, as well as those who were using a pump without automation, and on the right, automated insulin delivery. And you can see that the differences are greatest in the MDI users. The automated insulin delivery individuals who were receiving that had similar values for the first hour or so. And these shows the glucose excursion over 4 hours, again showing that the differences were primarily in the first couple of hours, and by 3 hours, there were no longer significant differences. So to summarize, combining both meal challenges, again, we're looking at glucose change from the start of the meal challenge. So the red line above is the meal challenge results when the individual received subcutaneous rapid-acting insulin analog. And they had the greatest change, the greatest rise in glucose with the meal challenges. The blue line shows the results from the initial dose of inhaled insulin for a meal challenge, and this is combining those who received their initial inhaled insulin dose at baseline and those who received their initial inhaled insulin dose at 17 weeks. And you can see that their rise in glucose, their change from the start, their glycemic excursion was less than those who received the subcutaneous rapid-acting insulin. And then the yellow line shows the data from the 17-week optimized dose, as the individuals received inhaled insulin for 17 weeks and now on a higher dose. And they had the smallest change in glucose from the start of the meal. That is the smallest amount of post-meal hyperglycemia. The treatment of hypo and hyperglycemia during the 2-hour meal challenge at 17 weeks is shown here. Again, by protocol, hypoglycemia was less than 70 milligrams per deciliter, for which oral carbohydrate was provided, and that was infrequent. And hyperglycemia was defined as greater than 400 milligrams per deciliter, over 300 for at least an hour, or investigator discretion, and there were a few individuals who were treated for hyperglycemia. So in summary, post-meal hyperglycemia was reduced with inhaled insulin compared to subcutaneous rapid-acting insulin analog. The reduction in post-meal hyperglycemia with inhaled insulin was greater for our MDI users than our AID users who continued AID during the challenge, but in sleep mode if they were using Control-IQ. And there was a greater reduction in post-meal hyperglycemia observed with the higher inhaled insulin dose at 17 weeks compared with the baseline dose. And lastly, post-meal hypoglycemia was infrequent with both inhaled insulin and subcutaneous rapid-acting insulin analog during these meal challenges. Thank you.
Thank you, Ruth. Now we're going to move on to hear the primary results of the trial from Carol Levy from the Icahn School of Medicine at Mount Sinai in New York. Carol.
Thank you. I'm a little height challenged, so if you can't hear, just start waving your hands or something. All right, so we're going to get started. Okay. These are my disclosures. So just as a reminder for those who may have arrived a bit late, this is the study protocol here that you can see in terms of randomization and completion of the study. What I will state is that what I want to remind everybody of, and it's just a little hard to see it here, is that about half the participants were utilizing AID, which is I think most of us would consider is the gold standard for care at this point. Okay. So, as a reminder, the outcomes were non-inferiority in terms of comparison with Technosphere insulin versus standard care. And what you'll see here is, sure enough, those outcomes were met in terms of P less than 0.01 for non-inferiority. If we dig a little bit deeper here, you'll see per protocol analysis very similar findings once again. So as a reminder from what was said earlier, per protocol analysis meant patients followed the protocol appropriately, dosed for meals appropriately, only 3 doses per week were permitted as not being completing the protocol appropriately or missing basal insulin for those who were basal insulin users. All right, so you're looking at this and saying, all right, so big deal, it's equivalent, that's nice. But there's more to this story. And the point I want to make here, and I'm going to spend several slides after this talking about this, is one size does not fit all. And this is where it really gets interesting. All of us provide care to people with diabetes, and a treatment regimen that works for one individual may not be as optimal for another, but for some individuals, it's the magic golden answer. So let's take a look here as I point to that information and think about what occurred in this study. And as a reminder here, Technosphere insulin is in red, and usual care usual care is in red, and Technosphere insulin is in blue. Sorry for that. So what you see here is a change or reduction in A1C. So those individuals on Technosphere insulin were a higher percentage who met the A1C under 7.0. As you move further through the slide, you will see that a higher percentage of individuals had a reduction in A1C of 0.5% or more. And then interestingly, on the other side of this, there was also a large cohort of individuals who had a worsening or a higher A1C compared to the usual care arm. That's a little bit interesting, but we can think about maybe some of the reasons, and Earl, I think, is going to get into some more details, as will Grazia later on. So when you look at this even more deeply, and this was, I thought, was a really cool slide, and I like it a lot, is what you'll see here is sort of the trend and the profile of distribution regarding A1C. And what you'll see is, not surprisingly, the usual care group was using their usual care, and they stayed about the same. There wasn't a broad change, maybe a little bit of study effect for some individuals. But if you actually take a look at this group, some individuals did incredibly well on this treatment, and others struggled more. And we can think about some of the reasonings behind that. So once again, thinking about this data, let's think about the A1C outcomes for those individuals with what we would consider less optimal glucose control and those with the A1Cs greater than 7.0. And what you'll see here, once again, is a large number of these people achieved an A1C under 7. And there really wasn't a change. For those who were doing well on their standard of care, they continued to do well. The A1C improvement also was really notable in terms of comparing the two groups. And then finally, once again, A1C rising was also more pronounced in the Technosphere group for those who struggle with that type of regimen. Does that mean it's a bad regimen? No, it just means one size doesn't fit all, which what we've known for years and years about care of people with diabetes. Okay. So what about hypoglycemia? As everyone's aware, this is a more rapid on, rapid off treatment. So did that lead to more hypoglycemia? And here, as you can see, this once again met non-inferiority, both in the less than 70 milligrams per deciliter, as well as less than 54 milligrams per deciliter. And just as a reminder to everyone in the audience, our time in range goals are less than 4% under 70 milligrams per deciliter and less than 1% under 54 milligrams per deciliter. And I think what's even more pronounced about this is about half of these individuals were utilizing AID systems, and we see almost the same outcomes. Okay, CGM metrics, time in range. We've gone through A1Cs, now we're going to CGM metrics. And what you'll see here in terms of data, and reminder, most of these individuals were not at A1Cs less than 7, so this 52% is not unsurprising here. And you'll see that there really wasn't any difference between the groups. Some of you who are looking really detailed might see a slight decline in terms of time in range here. I believe Grazia is going to get into that in more detail, so I'm not going to belabor that in the nature of time at this point. Okay. What about additional time in range, 70 to 180 endpoints? And once again, changes in time in range are similar and reflect what we saw with the A1C results as well. So once again, you'll see Technosphere insulin, a higher improvement in time in range greater than 70%, in a larger population, and I realized my mouse was in the wrong place. What about time and range improvement in 10%? That's pretty impressive, actually, and we all know if our patients do that, we say yay. But 25% for a larger number of individuals using the Technosphere insulin. Once again, you'll see the other side of this is that for some people, this just was not a great treatment option, but for a larger proportion of individuals, this was a really nice treatment option for them. Okay. What about other outcomes? Remember, surveys were done. We were looking at change in weight and other features. So in terms of patient-reported outcomes, there were no significant differences comparing the treatment groups at 17 weeks. Okay, no differences, and you can think about, well, that's interesting, but patients' certain features were preferable for them in terms of the ability to take this insulin right before we eat. And I just want to make a point here, which I know is going to be pressed on later on, is do you know how hard it is when we ask our patients to wait 15 or 20 minutes before they eat? It's not easy. Okay. What about weight? You might say, well, some of these people who improved in terms of glycemic control with their weight have increased. And what you see here is non-inferiority once again, or equivalence between the two groups. We could start to quibble in terms of the slight changes here, but once again, no change in weight in spite of A1C improvement. Okay, safety. So, adverse events are listed here. You will notice there was a higher number of people with adverse events in the Technosphere group. I'm going to get into that in more detail. I think we can guess what some of those were related to. And then a listing of the adverse events throughout the study. There was one severe hypoglycemic event in the Technosphere group. That was in an individual, and we'll get into more details, but basically who had excessive alcohol intake and did not report use of the Technosphere insulin for many hours prior to this hypoglycemic event. It was a lot of alcohol. It wasn't one of our participants, but that was what was reported. And as we know, in an individual on basal insulin therapy, that can be problematic as well. Okay. So adverse events. The most pronounced one, not surprisingly, was cough. And in terms of that, this was typically mild at the time of inhalation, which is well known already and presented previously. And in most cases, it didn't affect the Technosphere insulin use. This is consistent with prior studies, and a sip of water typically resolve this. Patients would cough a little bit, take a little sip of water, and then they would be fine. Okay. What about FEV1? That's the other area that we need to think about. And in terms of FEV1, you see the baseline here. And then you'll see the results subsequently. And this is pretty much the same as all the other studies, exactly what we know and exactly what we've seen. And there were no individuals who had a reduction in greater than 20% of FEV1. Okay. So summary of key results here, and I'm a New Yorker, I talk quickly, I hope everyone's been able to follow. 123 individuals, approximately half of them on AAD systems. 93% of them completed the trial, and the primary endpoint of A1C non-inferiority was met in both intent to treat and per protocol analysis. As I mentioned previously, and this is where I think it's really interesting, the Technosphere insulin group had a higher percentage of participants with an A1C less than 7 at 17 weeks. The A1C improved greater than 5% in the Technosphere insulin group in a higher percentage than those in usual care. The time and range increased in a higher percentage than those utilizing their usual care. And the time and range improved by greater than 10% in a larger number of individuals. We're going to share the full story here. And as everybody knows, on the other side of this, there were those individuals that had a worsening A1C and a worsening in terms of time and range. But once again, a lot of patients really did better utilizing this insulin. In terms of key safety results, CGM and hypoglycemic metrics once again met non-inferiority criteria comparing TI with the usual care groups. The amount of CGM measured hypoglycemia was low in both groups. As I mentioned already, there was one severe hypoglycemic event that was presumed, as best the data was available, not related to the use of this Technosphere insulin. There were 6 AIs in the TI group that were associated with pulmonary symptoms, and none of these were felt to be serious. Cough was reported, very similar to the data that was previously presented, and it was mainly transient. And the FEV1 had no significant differences between the groups at 17 weeks. I thank you for your time and your interest.
Thanks, Carol, for that excellent presentation. Now we're going to hear from Grazi Aleppo from Northwestern University in Chicago, who's going to expand further on some of the results.
Thank you, Roy. All right, we're going to dig into the results. These are my disclosures. 6 seconds. 5, 4, 3, 2, 1. Done. Okay, I'm going to go over again about the distribution of the insulin delivery method from pre-study. So these are two groups. The ones that were on the went to the TI degludec group. It was a good distribution between IAD, MDI, and standard pumps. And the usual care is similar distribution between IAD, MDI, and standard pump of low predicted glucose suspend. We're looking here at two different groups. On the left side, you see the A1C outcome in the pre-study MDI. So these are people who went from MDI or standard pump to TI, or AID who went to TI or remain on AID. So on the left side, see there is no difference between the group of A1C from baseline to 17 weeks for people who were on MDI and went to TI. Similarly, there was no difference in the A1C baseline to 17 weeks for the groups who were on AID and went to TI. But if we look here in this distribution of the previous users that were MDI to TI, you can see that it was the same thing that we showed before with Carol. There was significant people who went up in terms of A1C less than 7% at 17 weeks. And two groups, those who did better than 0.5%, so got a better improvement, and those who actually worsened the A1C of more than 0.5%. Similarly, as far as time and range, you see that a good percentage of participants went over 70% at 17 weeks for the people who were using MDI then to TI. But then you see there was again an improvement of time and range and also a worsening of time and range in this group of people. And the participants who were using previously AID and went to TI, you can see that the A1C also had similar numbers between TI and usual care, and it was the groups that we saw again, they improved the A1C but more than 0.5%, and those who worsened the A1C of more than 0.5%. What about time and range? These are previous AID users who went to TI and then the ones who continue AID. Again, there is a similar distribution of time and range above 70% at 17 weeks, and those in whom the time and range improved by more than 10%, and again, more of them whose the time and range worsened by 10%. And so we need to look at this slide with a bit more attention. So on the top in the red, you see the usual care of the people who were they were on MDI. And you see how there is this very compact distribution of A1C. Similarly, for the ones who are user care on AID, very compact distribution of A1C. If you look at the left side on the blue portion, you can see that the participants who were from MDI went to TI. You can see how wide that is, and even wider yet, of the ones who were from AID to TI. And so there is the majority of them are really in the sort of improvement, but you see how some people, like the outliers on the right side, didn't take the dose of TI. Let's be honest with each other. Time and range below 54 was really low, whether you were coming from MDI or from AID, and remained the same. So that was very comforting that there was very little hypoglycemia, and regardless of the group of pre-study. Time and range. If you look on the left side, you see that it was overall in the TI group, similar in time and range between daytime and nighttime for the people who are coming from MDI to TI versus the ones who stayed on MDI. And the numbers were a bit better for the participant who went to TI group from the MDI. If we now look at this slide, this is an important slide to pay attention to. The time and range between 70 to 180 for people who were before study on AID who went to TI versus the usual care group. That is, on overall, 50% there is no difference. But if you look at the nighttime, there was a decrease of time and range in the participant who went from AID to TI. And let's find out how that was explained. It's very important to see this. I'll spend more time on this slide because it's a very important slide to discuss. Okay. First of all, I want to point out that these are three colors. Of course, the red is the usual care MDI or standard pump. The green is the usual care, which was AID pre-study, and the blue is Technosphere. If you look at the red group was the MDI, usual care. They did the worst. They were above all the possible glucose compared to the other two. Now we need to focus on the difference between AID and TI. If you look between 8 o'clock in the morning to 8 o'clock at night, the numbers are overlapping. So there is no difference between AID users and TI. That's pretty remarkable. And they diverge at 8 o'clock, 9 o'clock at night. So that, and of course you can see overnight how the AID users had a lower glucose, which we expect from an AID system to do that. So how we can possibly explain the divergence between the 8 p.m. to 10 p.m. overnight? That is because there was supposed to be an optimization on the participant side of taking the second dose of TI after dinner. And most importantly, it is the bedtime correction that makes a huge difference. For those who did, they got better results. If you look then at various factors about the outcomes, there is no difference between age, sex, ethnicity, duration of diabetes. These factors do not really affect the results of the study. Let's go summary overall. First of all, the control group had either MDI or AID users and very few non-automated pumps. The distributional change in A1C was much wider in the TI degudec than with either pre-users MDI or AID. And more participants had a substantial improvement of hemoglobin A1C for the TI group, but also there is this dichotomy of more than 5% improvement and more than 0.5%, worsening. Both treatments have very, very low hypoglycemia frequency, whether they were coming from MDI or AID, and that's very encouraging results. What about the summary for the participant who went from MDI to TI? Among this group, 17 weeks of A1C was better in the TI group in terms of A1C reduction, and they have a much greater amount of group percentage of people who have A1C less than 7%, 30% versus 4%. There was a greater percentage of improvement of 0.5% A1C in the TI group, 23% versus 11%, but there also was a percentage of worsening A1C more than 0.5%, 23% versus 4% in this group. And then the time in range was slightly better in the TI, both during daytime and nighttime. It's important to remember that this is the MDI going into TI. What about the AID participant? Among this participant who went from AID switched to TI, the percentage of 17 weeks A1C less than 7% was similar, 30 to 33%, so between the two groups. And the percentage of improving the A1C by more than 0.5% was higher with TI, 19 versus 0. But we also saw this discrepancy where you see a worsening of hemoglobin A1C more than 0.5% with TI. During the daytime, the CGM time in range was similar between TI and AID. But overnight, and I showed you before, the CGM time in range was higher in AID compared to TI, emphasizing the importance of taking the post-bolus sort of correction we call booster, and especially the bedtime correction to optimize the glucose level before going to bed when using TI. Thank you.
Thanks, Grazia. Now we're going to hear from Earl Hirsch from the University of Washington, who's going to give us his thoughts about what all this means. Earl.
Thank you, Roy. Simple, right? Okay, so let's think through this for a moment. These are my disclosures. What did we learn? Well, first of all, compared to the rapid-acting analog, the TI minimizes the post-meal glycemic spikes. And I think it's important to realize that when we started at randomization, it was about a twofold increase using these Afrezza units, TI units. But we didn't know. And as the study went on, we were able to optimize, and we actually learned as we went how much insulin was needed. And that's why you see in the yellow line at the bottom, you clearly see that we learned that we needed more insulin than, let's see there we go. We needed more insulin at the beginning of the meal to prevent that postprandial spike. I want you to realize that we're here, between 20 and 30 milligrams per deciliter above baseline. So, we can really mitigate this postprandial spike once we learn, there we go, once we learn how much insulin we need. So, we talked about this as an Afrezza unit, and we knew at the beginning that we couldn't compare this to an injectable unit from the rapid-acting analog. So at randomization, we estimated that it was about 2 Afrezza units would be bioequivalent to 1 RAA unit. But what we learned was that wasn't enough. And at 17 weeks, we realized we needed somewhere between 2.5 and 3 times higher than the RAA at baseline. And when we looked at the ratio between the basal insulin degludec and the prandial TI, it was actually a 30%, 70% ratio. And that's not what we teach. That's not what we generally do. But with this insulin, this is the general ratio that we saw. And so I think the bottom line take-home point, we need to understand appropriate dosing for both the TI and the basal. Now, the primary results you saw, this doesn't tell the whole story. The story is a bit more complicated than this. And my take was, this was a positive outcome because we learned so much about how to use this novel insulin. So, looking at the means doesn't tell the whole story of what you just heard. So, I say that, and I show this again because it's so important. If we look at the entire study population, for those who ended up with A1Cs less than 7% at the 17-week part, we had 30% in the TI group versus 17% in usual care. And for a significant A1C improvement of more than 0.5%, it was 21% with TI versus 5% of usual care. But these are the responders. We also had people who we could call non-responders, where the opposite happened. The A1C actually worsened by 0.5% in 26% of the TI group compared to only 3% in the usual care. And that's why when you see the results of the A1Cs for the primary outcome, it doesn't tell the story about responders versus non-responders. For those who started with A1Cs above 7%, nobody, absolutely nobody in the usual care group got below 7% at the end, whereas it was 21% in those with TI. Furthermore, what we see in the, I realize the arrow's not working here, 28%, there we go, I'm sorry, 28% in those individuals with TI had an improvement of greater than 5% if they started above 7% compared to only 7%. There we go, for A1C, with those individuals starting with A1Cs above 7%. But then once again, we see the same situation where 21% of individuals actually had their hemoglobin A1Cs worsen by 0.5% if they started above 7% compared to only 2% with the usual care. This distribution curve is really important because what we see here is we see this dramatic improvement or worsening of A1Cs in the group with TI, whereas in usual care, we see this normalized curve, which is relatively tight, with individuals staying pretty much the same during the course of the study. So I think one of the things to realize here is that TI is not for everyone, but for some, it's really an important option, as you can see with the A1C improvements. Now, I want to go over this curve again because it's really important. First of all, when we look at the group with usual care, MDI or non-AID pump, it's interesting to me that the mean glucose levels stay above 200, both overday and at night. But it gets much more interesting. If we look at the green, which is the AID in usual care, I want you to notice, yes, their glucose levels are improved at night, but think about this for a moment. The targets on these AID systems are much lower than the nadir here of 150. That's generally not where we keep these patients, especially we had a lot of tandem patients who were on sleep mode, and that has a target of 112.5. Well, our individuals weren't even close to that. And then what you see here in the blue line is you see the glucose levels staying pretty much the same during the day, but you see the separation at bedtime. And in the blue line here, at bedtime, the glucose levels are a bit higher than they are in the AID. And this is really important. We talked before about the need to dose several hours after eating. And what obviously happened here is the patients who responded dosed both at bedtime and during the day. The bedtime one, I think, is perhaps the more important one, because if they didn't dose when they were high at bedtime, they didn't get their glucose levels going down. We still had this trend down in the TI group, but it didn't match the AID group because not everybody was dosing at bedtime. And that was, I think, one of the main reasons for the differences that we see here in the study. I'm going to show you a patient of mine. This is before randomization, A1C of 7.6 on tandem, time in range of 52%, with GMI of 7.6, not doing great, not meeting target. He then went on to the TI, and the other thing is the control IQ autobolus was quite high, 21%. 21% of the prandial insulin because his blood sugars were high much of the time. Now look here, he is not completely done with the INHALE-3, but you can see that his time in range improved to 61%, his GMI improved to 7.3, still not at target, but improved. But much more interesting is when we look at the AGP. What he was doing was he was having a meal, essentially a second dinner. His BMI was well above 30, but he was having a second dinner here as his TI from his first dinner was wearing out. So he dosed here at bedtime for his second meal. His blood sugars came down nicely into target by 2:33 in the morning, but then he was out of gas. He was out of insulin. And he would wake up here in the morning with glucose levels well above 200 because we couldn't fix that with the Degludec, and he wasn't dosing in the middle of the night because he was asleep. And what was really interesting about this is he knows he shouldn't be eating a second dinner. He didn't need it. And instead of trying to get fancy and setting an alarm and waking up, he says, you know what, doc? I'm just going to stop eating that meal. That's just not doing me any good. And that's literally what happened. So let's talk about some takeaways for success with TI. It's knowing how to optimize the basal insulin. How many of our patients come in on way too much basal insulin? We see this all in our clinics every day. We use the beam score, that is the average bedtime glucose and look at the difference between the average fasting glucose, and we want that number less than 30. Really important to have the right dose of basal insulin. We use Degludec in our study. Willing to dose 1 to 3 hours after a meal, especially if high protein fat. And our non-responders, they obviously were not doing that. Willing to dose, and at what dose for bedtime hyperglycemia. And it's important because we're not using sensitivity factors, we're not using carb ratios, we're thinking about diabetes differently. But patients figure out, do they need the 4 unit, do they need the 8 unit, or a combination of them? And then the timing of insulin is really important. We talk about this a lot. Timing of insulin, if you're at a restaurant and the food doesn't come, you don't want to dose not knowing when the food is there. You want to dose when the food is there. Same thing on an airline. You're about to get fed and the flight attendants have to go back because of turbulence. You need to wait until the food is there before you dose. More takeaways for success. It's not to overtreat hypoglycemia. The insulin is in and out so fast, you don't need the typical 15 grams most of the time. Exercise is critical. Yes, using TI and exercising within 30 to 60 minutes afterwards is difficult. But on the other hand, exercising more than an hour or so after the dosing, patients did not have the exercise. And in fact, this was a major reason why some of my patients wanted to stay on. It was because they could exercise easier without treating hypoglycemia. Finally, the starting dose, you have to be more aggressive than what's in the US package insert of 1 to 1 or 1 to 1.5 for starting dose. And we found out twofold was still underdosed. And as a rule of thumb, it was 2.5 to 3 times the rapid acting dose, which we found to be both safe and effective. At least why subjects in Seattle decided to remain on the TI after Inhale-3. Some of them were tired of being on a pump. For pump patients, no worries about skin challenges, frequent infusion set failures, and ease of travel. They didn't have to take as many supplies with them. They can exercise easier without worries of hypoglycemia. This came up over and over with our patients in Seattle, and easier to achieve improved glucose control, at least for some of our patients. And finally, this is still a work in progress as patients are now coming off the extension phase. How many want to stay on the TI when they are done? Overall, it was 53% of our population wanted to stay on. If they were on MDI pre-study, it was 60%. 43% wanted to come off their pumps, which was very interesting. And then 60% if they were on pre-study SAP. And we didn't have a lot of SAP patients, just 5. The most important learnings, using TI may be good for patients who are engaged in their diabetes self-management and want to reduce hyperglycemia even further. Using this insulin may be good for patients who want an alternative to a pump. To maximize the benefits, they need to repeat inhalation 1 to 3 hours after meal if the glucose is trending above 140. What the really good patients would do is they would put their alarm on their sensor at 140 or 160 and they would bolus again. They would dose again once it hit that. And it is important for the clinical care team to understand how patients can get their best results from this therapy. What it suggests to me for future studies, using this insulin for AID, for hyperglycemic rescue, for all prandial insulin, and we often think about this for gestational or pre-gestational diabetes where we know the postprandial spikes are so dangerous. I want to mention there is another study called Inhale-1, which is a pediatric T1D randomized study. It's another phase 3 RCT comparing TI with basal insulin versus RAA and basal insulin in youth, 4 to 17 years of age, with either type 1 or type 2 diabetes. It's a 6-month randomized controlled trial followed by a 6-month extension using TI basal insulin regimen. There are 40 sites in the US, as you can see, with 222 participants completed in March of 2024. You will hear more about that study later. And with that, I thank you for your attention.
Thanks, Earl. So our final speaker is going to be Tom Blevins from Texas Diabetes and Endocrinology in Austin, Texas, and he's going to talk about his experience using inhaled insulin in clinical practice.
Thank you. So how do we take this information? This is a great study, really interesting study. How do we take it back to our practices? And when we see people on Monday, and the answer is, first of all, those are my disclosures, and there are a number of reasons to use TI. What I'm going to do is talk a little bit about a couple of cases, some rationale, some clinical things, and then I'm going to also talk about some kind of a continuation of best practices. Well, one reason to use TI would be, Technosphere insulin, would be patient's choice. And when we show people this data or talk to them about it, they may decide they might want to try it, and we may want to just give them a chance to try it. It controls the postprandial very effectively. You saw that earlier. Rapid in, rapid out is important. Less chance of stacking. discreet and convenient. These are things patients have told me, told us. And then needle phobia, lipohypertrophy. Those used to be kind of at the top of the list for me, but now they're important, but they're toward the bottom of the list. So there are reasons to use and there are reasons not to use. Certainly if a person has chronic, recurrent pulmonary disease, asthma, COPD, they probably shouldn't be using it. It actually should not be using it. And if they have hypersensitivity to human regular insulin, contraindication, of course. Pulmonary function tests need to be done. This is the practical stuff we can do in our offices. And we need to do this. It's recommended, and this is what we should do. Assess pulmonary function, spirometry at baseline, and every 6 months of therapy, even when there are no pulmonary symptoms. And also, if the decline in FEV1 is greater than 20%, stop the medicine and do something else. In our office, we have a spirometer. It's easy, and the MAs do it. I can do it. If I can do it, anybody can do it. And I use the spirometry. It's a very easy. That's the machine. That's taking a picture right on a desk at our office, and with those disposable little inhalers too. You've seen this information before already. This is something I talk to people about. This rapid in. Look on the right-hand side. This is the pharmacodynamics. That's the important part. And you can see that really as this insulin gets in quickly, and you saw the postprandial effect a while ago. And also you see by the time the Lispro is starting to peak, the TI is actually getting out. So you can actually dose again at 60 minutes. I'm just showing little lines there. 60 minutes. You could do it again at another 90 minutes if you wanted to, if the patient needed to. And this thing about dose conversion is incredibly important. You've heard it over and over again. I'm just going to mention it one more time. And as the PI says what it says, but what we found in the study is that 2 units of rapid acting analog is really 4 units of TI, and 4 is 8, and 6 is 12. Now I tell my patients this all the time. 2 is 4, 4 is 8, 6 is 12. And making this conversion is important. As Dr. Hirsch pointed out, actually, there should be a little bit more Afrezza probably, that is TI probably, but actually the way I start in my clinic is I just say double and use this formula, 2 is 4, and so on. And this works very well, and then you can titrate from there. These are some of the guidelines we used in the study, and I think they're worth looking at and eventually establishing best practices because they worked. And some of the things we had to alter during the study. Remember, people may have to use more than 1 cartridge to get the dose they want. That's number 1. And at the time of the meal, the people may want to adjust their dose. For example, if the meal size is larger than usual, they may want to take an extra 4 units. If it's smaller, 4 fewer. And also, if the glucose is elevated, they may want to take more. And these are things we talked to people about in the study, and these are things that worked. And we can talk about that more in detail at another time. And also, the next day, they may adjust the mealtime dose of TI using like table 1. And just look at the bottom of table 1. For example, if on one day at 60 to 90 minutes after a meal, the glucose is over 140, the next day you might titrate the dose up. This is what we do with sub-Q insulin all of the time also. Give a correction dose in the following situations. You've already heard a little bit about this. As soon as 60 to 90 minutes after the meal, and I'll repeat that, as soon as 60 to 90 minutes after the meal, because of the PKPD, which you know about. You've seen 3 slides or 4, same thing, PKPD now, and you know it already. The person can give a correction if the glucose is elevated, and they may have to give the correction 1 to 3 hours after. If the meal is, for example, a higher fat meal, it may peak later. And if they see themselves having some rise after the meal, they could dose again. You would not do that with sub-Q insulin. I would say you don't dare doing that because you're going to stack. And the alarm could be set. In some patients, we actually had the alarm set during the study at 140 and greater, and they would dose above that, believe it or not. And they'd bring the glucose down and kind of guide the glucose back down. And some people wanted to set it higher. Some people didn't want to do this. This is individual. And then reduce, delay the correction dose if the glucose is dropping before the meal. You know, the trend is down. All makes sense. And correction dosing at bedtime, as it was pointed out by Dr. Hirsch earlier, really important. You really need to guide the glucose back down at bedtime. And this is fast acting in and out. I'm going to show you a couple of cases that make a couple of points. This is a person on the study, 29 years old, and she was on AID when she started the study. Her baseline A1C was 7.6. Time in range at start was 64%. She was on about 35 units of insulin total daily dose. And we converted her, you can see the bottom right here, to what was essentially the equivalent of what she was doing with basal. She was on about 20-something units of basal on the AID, so we gave her degludec of about that much. And then we gave her, she was on approximately 4 or so of rapid-acting insulin, so that is per infusion in the pump, and pre-meal, and so we doubled that. And then eventually we titrated it, as you can see, up. And eventually, I'll tell you, we titrated back down. You can see the kind of what was going on here upper right. This is pre-study. And then on study, this is just 1 day. And this is about a month after she was originally randomized. And what you can see is a few things that are important. These are doses. I don't think you can see the numbers very well, but these are doses of TI. And she took dose here. She went to bed quite late that night. Her glucose was up a bit. She guided her glucose back down with that dose. That's that bedtime dose we talked about. And then she got up kind of early, wanted to lower her glucose. She took a very small dose of inhaled, dropped it down. At the mealtime, you can see these are meal times. She dosed, and dosed. And we had to reduce her mealtime dose eventually because she was dropping a little bit too low. And so what you see, though, is that about an hour and a half or 2 after the meal, her glucose was up higher than she wanted. She took an extra dose. She did it here again. So she guided the glucose back down. And that's the relevance of that. What we learned from her is that in between meal dosing was very effective. You can see her times in range for 2 weeks when she was, it says post-study, but that's on study. She's on study. Her A1C is down to 7.1%. What did she do after the study? This is important, patient choice. She went back to the AID, but she used TI as a prandial insulin. We can talk about that later if you want. We had a few people who wanted to do this. And also what worked for her, the rapid effect, that's what worked for her the most. And then we did have to change her basal insulin a few times. Now, another case is a 72-year-old male, type 1. He was on MDI with actually Dedimer and Lispro AABC. To the left, you can see his time in range. You can see that it's kind of chaotic. He misses lots of doses. And he's a busy guy. He is. And so we put him on the study. And 1 month later, he's on degludec 12, and he's on pre-meal TI. And what do we see? Well, I'm going to just go quickly through this, but things are much more even. He's found that this is very convenient, very discreet. He's in business meetings. He just pulls out the inhaler, inhales, and he's reduced his variability. You can also see on study, his time in range here has gone up on average to 77% from, remember, it was 57%. And what did he do after the study? He stayed on TI plus degludec. That's what he wanted to do. And he liked the rapid effect. He felt more in control. He felt it was discreet in his life. And so he became very adept at dosing between meals, I'll tell you that. That was what I observed. And he learned a lot himself after about a month or so of being on the med. This is a 31-year-old, just briefly, things didn't work out so well. It doesn't always work out so well. He was on AID prior to the study, A1C is 8.2. He forgets to bolus. He forgot to bolus on AID. He's forgetting to bolus. This is on study. He forgets to bolus prior to meals. And we're working on it. And so what worked for him, he liked the fact that he didn't have to wear a pump. He liked the fact that he could get that rapid onset. He has a fear of hypoglycemia too. So things aren't all just rosy here. And I will tell you though, he kind of decided to stay on the TI after the study, which is really interesting. And so what happened, you saw the data overall. I think our data at our center helped kind of push up the numbers, percentage of the people who stayed on TI after study. And what did we see? We saw that in the people who were on AID pre-study, one went back to AID. She had a little bit of a cough that continued, and she didn't want to have that happen. And then 2 stayed on TI plus degludec, and 1 was leaning that way. And that one who was leaning is the last guy I showed you, and he's asked me to write a prescription for TI for him. And then 1 went on, the one I talked about that went on AID plus TI. And then about 50% of the people who are on MDI stayed on TI plus degludec at our site. So when you're talking to patients, what do you say? Rapidity of effect is one thing that's really important. And how do you translate this information when you talk to people in the clinic? You want a concise message, as you do with anything you do when you're in the clinic. And discuss the dosing an hour or 2 after they may need to do, and it's an option. Discuss that dose conversion. That's a big deal. Show the delivery device. I do it in clinic routinely, and I'll tell you more about that in a minute. Talk about side effects, always cough, sore throat, it happens. Spirometry is a big deal too, and you want to get that in and get all that going in the clinic. I keep the device and cartridges in my exam rooms, along with everything else. It's kind of hard to see the desk in my exam room typically because there's all kinds of stuff on it, but you can see the device there. And you can show a person in the office very easily how to use it. The cartridges are very small and play with it. And that's, I show them how to inhale it. I never put it in my mouth. For the picture I did, but anyway, keep it clean. So these are comments we got from patients who were in this study, not necessarily my patients, of course, from other doctors sometimes, but one was, these are comments you get from patients and you kind of don't want to get from patients sometimes, like, no one told me that this option existed, like, oh, okay, it's been out for 10 years. Is this insulin new? And that's another one, and why didn't we start this before? We can talk about these cases later if you want to, but finally, the INHALE-3 study is really instructive to us as clinicians. It tells us how the med works. We learn about conversion. We learn about best practices. And my final comment is I'm going to suggest that we have this group get together and maybe Dr. Hirsch, Earl's Pearls we used during the study, and come up with a paper that talks about best practices. How do you, in the clinic, use this insulin to its best advantage? We learned a lot from INHALE-3. Thank you.
Yeah, thanks, Tom. That was great. So if there are questions from anyone in the audience, you can come up to the microphones there, and we'll take some. Great. Looks like we have our first one here.
Hi, Sun Kim from Stanford. Thank you so much for this great talk. I do think it's very practical. I would love to see Earl's Pearls coming in the future. Many of you mentioned the heterogeneity of effect, and I'm wondering, some speakers alluded to who might benefit the most, but I'm wondering if you have a better sense of who those individuals are. And secondly, on potential cancer risk, that was always a fear way back when. And if you had a patient doing really well on this and say had a discovered pulmonary nodule, what would you do? Thanks.
Well, those are two great questions. So in regard to the first one, it is a really, really important question to try to understand from the data we have and clinical experience who is a good candidate and likely to do well with it and who's not. And so we're trying to dissect the data to look at that exact point, even dissect some of the baseline participant-reported outcome measures that we have to do it. But maybe, Carol, you want to take that and see just from your experience what you'd say?
Can people hear me? Okay, yeah, good. So, I think the most important thing, and this is something we learned from the trial, is to have a discussion with the patient before you proceed with any treatment regimen. You explain how this insulin works. You say what are the advantages and what are the potential considerations. You go through, you may need to be very cautious about a person with fear of hypoglycemia because many individuals who are on basal insulin are terrified of that bedtime dose, whether it be subcutaneous or inhaled. And you need to really review and iteratively discuss the CGM data and learn from it as time goes on. But I think there are many individuals who don't dose pre-meal that really may derive advantage from this because they can literally take it 1 second, as Earl alluded to, before they eat, and it will have impact. And that's where we struggle with a lot of our patients. So I think that that's a group that's one that would derive significant advantage. And of course, anyone who's tired of using their closed loop systems or have severe lipohypertrophy or atrophy is another group that you would definitely consider. I'm sure others have other suggestions.
So, exactly. So what I found to be interesting is that we need to teach our patient the opposite of stacking,
Right.
because they can, meaning that the patients of mine who I've actually prescribed Afrezza are the patients who cannot bolus pre-meal for whatever reason, but also tend to overdo it with rapid acting, and they end up having hypoglycemia. So for those patients, when you just explain to them you can take the dose after you eat and just take more than one, and they actually feel more relieved. So I've had the experience from people in the study and people who actually, I started using Afrezza during the study, not the patients in my clinic.
You know,
We all know patients, they dose right before the meal, they see a really high blood sugar postprandially, they sort of panic, they take an extra correction bolus, and then they go boom. So this is where I think that this really does provide a discrete advantage for individuals.
You know, I have one patient who is in this trial. She is actually a healthcare provider, and she was on AID, and she came into the trial, and the problem with AID is she didn't bolus. I mean, it was out of sight, out of mind. She has 2 little kids, and we were very excited. She was excited. Her husband was excited to go in. But what happened was she didn't bolus on AID, and she didn't bolus here either. And it was not pretty. And so, you know, not everybody is like that, but in her case, it wasn't a good idea. I had other patients, one in particular, severe fear of hypoglycemia, blood sugar is always 180 to 200, and she did fantastic. She was, and I didn't think she was going to do well, and so my prediction wasn't right a lot of the time. My only other comment, something that is so important, is when you're correcting a high blood sugar with TI and you see those 2 arrows coming down, patients freak out. But it's off so fast, the sensor then comes flat relatively quickly, and patients need to know not to overreact to the arrows. That came up over and over and over again.
Yeah, one thing, unfortunately, we don't have pump downloads for those who switched from AID onto the TI and degludec. My guess would be, similar to a case Earl said, that particularly with the control IQ, if you see that there's a large number of auto boluses that they have, and their A1C is 8 or so, they're probably missing boluses, and unless they really are committed to do the TI, they're probably going to do worse because they're going to miss out on that auto bolus from the AID doing it. I think we'll try to hit some more questions. Mike?
Thanks, Roy. Mike Rickles, Philadelphia. Great session, and congratulations on a terrific study. My question may be for Ruth on the meal challenges, because over that 17-week optimization, you showed there's even further improvement in the postprandial control, but it also seemed to be that relative to the usual care, that the difference was less at 17 weeks than at baseline, and particularly in the AID group. So I guess I was wondering whether there was also optimization occurring for the usual care participants over that 17 weeks, or how do you explain that narrowing of the delta?
Yeah, I mean, certainly the rapid-acting insulin could also be adjusted during that time.
Yeah, that's what I would think also. I mean, the control group had the same schedule, so during that first month, they had all those visits, and they likely optimized their dose better, and so we see less effect. What we haven't done, what we could do is try to sort that out a little, but I think that's a good thought. Next question.
Yeah, Walsh, San Diego. I do think the AID group could really benefit. We do have patients who you can tell that they're not bolusing pretty readily. So that group would be quite interesting. But the concern I have is about the cost of aphasia. For the average user, the cost comes out to about $2,300 to $2,500 a month. And that seems like a high price to pay for convenience.
Yeah, I think we'd say it's more than convenience, but Earl, you're our guru on costs. So.
I don't know if I'm a guru on this topic. I know a little bit about insulin costs, I guess. So, I mean, you're right. First of all, nobody pays that much, and pretty much everybody can get it. I will tell you that you have to go through a specialty pharmacy. They're very good. But what the company has done for anybody who is not able to get it, and I don't think we have anybody, at least at my site, that has had to do this, is you can get the insulin per month through the company directly for $100. So nobody has to pay that kind of money for this insulin.
Yeah. But it would be nice if they brought that price to the pharmacy.
Over here? Oh. Satish, of course.
Good job, guys, for doing an excellent study. My question is, since many people insulin requiring are getting overweight and obese and having to go on these GLP analogs, semaglutide or tirzepatide, off-label of course, how do you dose TI in those individuals who are on the GLP analogs?
Anyone have experience? Early, you want to take that?
You don't, not in type 1 diabetes. I mean, it doesn't make any sense to have a longer duration with a delayed gastric emptying and using TI. With that being said, using it as a rescue insulin potentially, that makes sense. But if you have somebody using off-label with T1D, it just doesn't make sense to me anyway.
So just my own experience, having had now nearly 500 people who are on these drugs at the Barbara Davis Center. Actually, if you do use the GLP analog and don't use the conversion that you guys did say, use the usual dose, it works pretty well, actually. So don't give 2.5 to 3 times. The studies we did, STAT and many others on the Afrezza, clearly shows taking additional boluses helps the cumulative. But here, if they are on a GLP analog, just don't increase the dose. It works pretty well.
There's your next investigator-initiated trial, Satish.
All right, well, we'll call that Satish's pearl.
I have one additional question for Satish, sorry. So with those, so we obviously could not enroll people in this study. We would have loved to have in that circumstance because, of FDA approval. Did you find they needed a subsequent dose because you had reduced it initially due to the delayed gastric emptying later on?
So very good point. And I don't have the data on that. I just published 3 manuscripts on using either semaglutide or the tirzepatide.
Yeah.
Now we are looking at all the comparisons. Very few people were using the TI. Unfortunately, because of the cost and the prescriptions, they have to take 2 different insulins. Anecdotally, I can say very rarely did they have to take a second dose.
Yeah.
Because it's really the GLPs inducing a very low glycemic index, so they didn't need really.
Okay, thank you. Unfortunately, our time for the session is up. So 2 of you, why don't you come up and you can just ask us directly. And thanks so much for your attention and thanks for attending.